Hey everyone, Dr. Wasif Saif is a professor of medical oncology at the Donald and Barbara Zucker School of Medicine at Hofstra. He did his medical school at the King Edward Medical College in Lahore, Pakistan, followed by internal medicine residency at the University of Connecticut School of Medicine, and fellowship at the National Cancer Institute, the NIH, in Bethesda, Maryland. He holds several leadership roles, including the Deputy Physician-in-Chief and Medical Director of the Northwell Health Cancer Institute. He has more than 360 peer-reviewed publications, and he has been recognized in the New York Magazine Top Doctors as a specialist who is highly recommended by his peers and other health professionals. Welcome, Dr. Saif, and we look forward to learning more about and designing new treatment paradigms for pancreatic cancer.
Thank you, Jelani. Thank you, Dr. Roy Weiss, and everybody. It's a great pleasure to talk to you today. And thank you very much for Miami, because we have a sunny day today. So I think probably just because of the reason I'm talking to you in Miami today. So without any further delay, we'll talk about a very serious disease today, pancreatic cancer. So the learning objectives will include to understand the epidemiology, etiology, and molecular basis of pancreatic cancer. We'll discuss the current treatment paradigms that we have currently available to these patients. We'll discuss about the rationale for development and use of novel therapies. And finally, we'll talk about our efforts that we have contributed towards the improvement in outcome for pancreatic cancer, finishing with the next step that we should be taking to end up this disease to be a curative disease. So pancreatic cancer is a devastating disease. We all know about it. Majority of those patients, unfortunately, are diagnosed at an advanced stage. When you look overall in this pie diagram, you realize that overall pancreatic cancer represents only 3% of all cancers, but unfortunately, it accounts for 7% of cancer-related deaths. At this time, no screening methods are available for general population, and also we have learned because of the genetic heterogeneity and complexity of the tumor, and maybe some factors which are hindering the delivery of chemotherapy to the core of the tumor, this tumor seems to be relatively resistant to systemic chemotherapy available at this time. In the United States, we saw about 60,000 plus cases this year, and we are losing about 48 plus thousand cases. But worldwide, the number is approaching almost 500,000 of the patients with pancreatic cancer, and the mortality rate is still very high, with an outcome is really basically, if you look at the mortality rate, is almost around 96 to 95% for this cancer. As I mentioned earlier, majority of these patients are diagnosed at the metastatic or locally advanced disease. Only 20% of the patient at the time of diagnosis are operable. Unfortunately, more than 80% come to metastasis in the next few years. Therefore, the cure rate remains to be around 5% with this disease. Looking at the projected cancer death in 2030, Dr. Raib and his colleagues had shown that by 2030, unfortunately, the tumor of the pancreas and the liver will be the second cause of death in the United States, followed by the rest of the tumors. So colorectal cancer, which is the second cause of death in USA, both for men and women, and breast cancer will be lower, while pancreas and liver will be the second cause of death, but the primary one will remain to be lung cancer. That really kind of worries us about pancreatic cancer as a disease. Despite all the developments, it's going to be a major killer, but also about the liver disease, particularly HCC. That means that NASH and hepatitis C and other things could be leading to more liver disease in the United States, which is a major public concern. So when we look at the etiology of pancreatic cancer, this pie diagrams define that majority of the cases are sporadic pancreatic cancer. There are about 5% of the cases where we are known to affiliate them with genetic syndromes. However, about 10% of the patients are the one where there's no known genetic syndrome. However, there's a cluster of familial pancreatic cancer in those patients. The two major institutions that collect information on those cases are Mayo Clinic as well as Johns Hopkins, where we're learning about those clusters which may have different genes, not similar to the one gene seen in the genetic syndromes. When we look at the risk factors, I edit these, these cartoons, particularly for my residents and fellows. It's very important to keep in mind that the risk factors are modifiable risk factors, so we need to learn about them. Smoking is a risk factor which can increase the risk up to 3 times higher, and it's a dose-response relationship. So it's not only the lung cancer, but pancreatic cancer is also one of the, outcomes of smoking. Similarly, alcoholism is also related to pancreatic cancer, not only just because of chronic pancreatitis, but there could be some other phenomena that may be leading to it. In a study done in the VA patients, it was found that pancreatic cancer was much higher in patients who were alcoholic versus other. And right now, the estimate rate is about 5 times higher compared to the general population. Coffee intake has a very interesting history. Going back in 1998 and 1999, there were a lot of concern that coffee may cause pancreatic cancer. It was later on Nishada who published a meta-analysis and showed us that probably the small amount of coffee may be protective effect in developing pancreatic cancer and maybe the large amount. Keep in mind that the coffee we drink in USA, it's very different than coffee. If you go back to a Chinese store and ask for a coffee mug, it's a very small coffee. So you drink a small 2 to 4 ounces of coffee. On the other hand, the coffee we drink in USA is like, grande and extra grande and putting a lot of other things. So who knows what will be the impact of other factors we add into our coffee. Fruits and vegetables are always the friends. However, we know that animal fat is a causative for many GI tumors. Similarly, citrus fruit could be a beneficial friend. It has limonene that lead to inhibition of KRAS. The relationship with diabetes, mellitus, and pancreatic cancer is like this chicken and egg. We don't know which one comes first. Historically, it was thought that patients who have diabetes mellitus more than 10 years may be developing pancreatic cancer. However, in the last 10 years, we found out that patients who develop diabetes mellitus with no risk factors, if they're lean, they don't have a family history, diabetes mellitus may be one of the harbingers or the first signs of pancreatic cancer. Similarly, pancreatitis, particularly chronic pancreatitis or Indian pancreatitis, which is an idiopathic disease seen in patients, account for about 5% of pancreatic cancer. Gastrectomy has shown to increase the risk, and last but not the least, high BMI. Moving to the genetics of pancreatic cancer, there are a lot of genetic syndromes which have been affiliated with the development of pancreatic cancer. Notably, I think there are some syndromes very important because now we have drugs to target those special mutations in the pancreatic cancer. Familial breast ovarian syndrome, which is the BRCA2, BRCA1, which is in the middle of the chart. Then, of course, HNPCC, which is MSI high, that's another important one. Then looking at further up, if you look at ataxia, telangiectasia, multiple mole melanoma, ATM, these are very important syndromes that not only they lead to development of pancreatic cancer, but now we have therapies which makes these patients more sensitive to certain therapies, which I will discuss later in the discussion. So it's very important to understand what are the signs and symptoms of pancreatic cancer. Painless jaundice, obstructive jaundice could be the most common sign, particularly in the patients who are developing mass in the head of pancreas. Unfortunately, fatigue, new onset diabetes, non-specific GI symptoms, mild progressive abdominal pain, which is really classically starting in the epigastric area, radiates to the back, anorexia, weight loss, and depression. So depression is not only that depression will happen reactively after you are diagnosed with pancreatic cancer, but actually in a study done in VA, it was found that about patients who developed depression and were worked up were found to have underlying pancreatic cancer as one of the causes. And that's the reason we define depression as one of the paraneoplastic syndromes in addition to thrombophlebitis in pancreatic cancer. The diagnosis really includes liver function, knowing that biliary duct can be obstructed by the pancreatic mass, or the liver metastasis can lead to liver dysfunction. So it's important to look at the liver function. You need to rule out concurrent pancreatitis. So testing the amylase lipase is very important. CA19-9 carbohydrate antigen is very important. However, in patients who lack the Lewis antigen A, which is about 10% of the Caucasian population, CA19-9 may not be elevated. That's the reason when I see the patient for the first time, I also collect CEA level. That's helpful because then I have some marker to proceed to look for a response to therapy. Imaging includes CAT scan as the gold standard. However, in some cases, PET CT scan can be done, particularly when you're looking for metastasis, which can make concern that patient may have a stage 4 disease. But the gold standard for getting a biopsy is really the endoscopic ultrasound through the FNA biopsy of the pancreatic mass. ERCP is required in opening this, looking at the tissue, but at the same time trying to put the biliary stent to relieve the obstruction in these patients. So it's very important to understand that this is a multidisciplinary management of pancreatic cancer that needs a gastroenterologist, that needs a radiologist, medical oncologist, a radiation oncologist, pathologist, genetics, nutrition. So it really takes a whole village to give the best to the patient care. So staging is very important, and I think the most important part that even we talk about any tumor to have stage 1, 2, 3, 4. I think in pancreatic cancer, we really go with a functional classification. The classification was first put by Dr. Staley, and later on it was revised by NCCN. So resectable patients are the one which have a tumor within the pancreas, which is resectable, not close to any blood vessels. On the other hand, when the tumor is going around superior mesenteric artery, superior mesenteric vein, or portal vein confluence or ciliary ganglion, based on those patients become locally advanced pancreatic cancer, or by definition stage 3. On the other hand, if the tumor is going around the blood vessels but less than 180 degrees, that is now more called like a borderline pancreatic cancer. And last but not the least, the most common group is the one who develop metastases in the liver, in the peritoneum, or distant lymph nodes or lungs. That's the metastatic disease. So we really use a functional classification because that it defines how to treat that patient and set up the goals of the therapy for those patients. And that's the reason what you see on the bottom line is resectable, borderline, locally advanced pancreatic cancer, and metastatic. So how we treat pancreatic cancer? So unfortunately, majority of the patient, I would say about 60 to 65% of the patients are diagnosed with metastatic pancreatic cancer, and they end up in receiving systemic chemotherapy. On the other hand, patient who has locally advanced pancreatic cancer, if they're resectable, they go to surgical resection followed by adjuvant chemotherapy. Patients who are locally advanced unresectable, they go with chemoradiotherapy. However, patients who are borderline, we try to offer them neoadjuvant chemoradiotherapy to see if those patients can convert into resectability of the pancreatic cancer. So let's look at the adjuvant therapy. So the adjuvant therapy is interesting because we are still somewhat divided across the Atlantic Ocean. So the European colleagues many years ago, going back to the early 2000s, learned that chemotherapy is the answer. It was the ASPECT-1 study published in 2004 in two pieces that showed that chemotherapy is better than no chemotherapy. However, adding radiation therapy has a detrimental effect. There were a lot of criticism of that study, however, we'll not go into the detail. Later on, a CONCO 001 study was done that looked at the gemcitabine versus observation and found that patient must be offered adjuvant therapy irrespective of the R1, R0 resection or lymph node status, because patients who do not receive adjuvant therapy, actually the disease comes back within 7 to 6 months and they die. Then later on, we tried to improve on GemSAR, which was the ASPECT-4 study, looking at gemcitabine plus capecitabine, which is the oral form of prodrug of 5-FU and anti-folic acid. And later on, 2018, we found that modified fall-free NOx, which is combination of folinic acid, 5-FU, irinotecan, and oxaliplatin, imparts the best overall survival in the adjuvant setting when compared against gemcitabine alone. In Japan, S1, which is an oral 5-FU with a combination of inhibitor for the DPD enzyme, which is the enzyme, the rate-limiting enzyme for 5-FU drugs, also showed that given S1 versus no therapy leads to overall survival of 46.5 months. Unfortunately, in the United States, the studies were really focused on adding radiation therapy, and the role of radiation therapy still remains to be determined at this time. But the challenge part is that is adjuvant therapy really adjuvant? Because as I mentioned earlier, R1 rates are as high as 85%, which means there's still microscopic disease left behind. We also know that 80% of the patients die of the recurrent disease after surgical resection done by one of the best surgeons in the world. We also know that most of these patients show to have perineural invasion, lymphovascular invasion, which really means that there's a persistent disease. And due to the complications of this surgery, unfortunately, at least up to 1/3 of those patients will never be able to receive adjuvant chemotherapy. So these are very important things that really kind of taught us over the last few years. And I think that led down the foundation for what we call neoadjuvant therapy or a pre-operative therapy. And the whole schema is that it gives you the benefit of offering a systemic therapy to a systemic disease in virtually all patients who are diagnosed with pancreatic cancer. It also allows to improve the patient selection, because we also know that we want to make sure that we want to really improve the R0 resection. We also want to spare those patients with aggressive disease, because keep in mind during giving neoadjuvant therapy, unfortunately, majority of the patient will declare to be stage 4 therapy. And also this will also allow not to really do surgery in a patient where they are not going to be able to either undergo surgery and come out successfully or will not be able to receive the adjuvant therapy. But last but not the least, that can also be helping us to learn about the biology of the tumor, whether the tumor is resistant or sensitive to chemotherapy, and finally we can improve the survival in those patients. And that has becoming more of the notion these days to be given to patient with even resectable patient as a part of the clinical trial. When you look at this strain of events, this is really kind of give you that how grim is to that has been for us to treat pancreatic cancer. Up till 1995, there was no drug approved by FDA to treat pancreatic cancer. And gemcitabine was compared against 5-FU. It was 1995 to 2005, at least 13 major randomized phase 3 studies were conducted both in Europe and USA. All of them were negative, were not able to show any benefit against Gemzar or in combination with Gemzar. Then it was gemalotinib, a tyrosine kinase inhibitor, which was shown to improve the survival slightly. Then finally, our European colleagues in France shows the FOLFIRINOX, again, folinic acid, 5-FU, oxali, irinotecan combination versus Gemzar to give us a survival benefit. Later on in USA, we did the IMPACT study that looked at Gemzar plus nab-paclitaxel, which is a human albumin-bound nab-taxol given with gemcitabine versus gemcitabine shows a survival benefit. It was in 2015 when the first time a second-line therapy was approved by FDA consisting of liposome irinotecan plus 5-FU leucovorin versus 5-FU leucovorin. And finally, as you heard me earlier, that patient with germline mutation of BRCA1 and BRCA2, as well as with ATM or RAD51 can receive olaparib, which is a PARP1 inhibitors after they have not shown any progression of disease, receiving 16 weeks of platinum therapy as the first-line therapy for pancreatic cancer. So as you can see that definitely there's more developments over the last 10 years than the previous 30 years. When you look at this, it would give you a little idea that what we mean by survival. So when you look at Gemzar plus 5-FU, the overall survival was 5.6 months with Gemzar versus 4.4 months with 5-FU. When you look at Gemzar plus erlotinib, the tyrosine kinase inhibitor, you can see the benefit was really 5.9 versus 6.2 months, which was very small. And that was the reason that despite this drug was approved in USA and Canada, the drug was not approved in the European Union and was not offered to patients. So people feel that even the study seems to be positive, does not seem to give any clinical benefit to the patient with pancreatic cancer. And then going further, then the study that showed the best survival so far is the FOLFIRINOX study, a combination of 4 drugs versus Gemzar of 11.8 months versus 6.1 months. And finally, the IMPACT study that was supposed to show a better outcome as we expected, but unfortunately, it was 8.5 versus 6.7. This is the gold standard approved by FDA in USA at this time. So when we talk about metastatic pancreatic cancer, it is very important to understand. I always tell my fellows to look at 3 things. Make a triangle, write down patient, cancer, and then finally write down the drug. So I think it's very important to understand patient's preferences and patient's comorbidities. It is very important. Second thing is cancer. Cancer means you need to know the tumor biology. Of course, you need to know the patient's stage. You need to understand the grade, but more importantly, you need to know the genetics of the tumor. As I mentioned earlier, now we have drugs which are targetable to these patients if they have certain genotype to help them out. And of course, finally, you need to understand the economics. And now we have first line, second line, and probably third line therapies for pancreatic cancer compared to historically, we have first line therapy and that's it. But in addition to that one, we know that there are differences in the first line therapy and we still use clinical judgment that we should offer patient either a FOLFIRINOX versus the gem-Abraxane therapy. It could be the schedule, it could be the performance status learned from the clinical trial, but we don't have any biomarker really to help us out to offer these therapy. And I think the field is really going into that direction of what we call precision oncology. And I think I'm very excited to share the next slide, this one, that now in addition to just like talking about exocrine pancreatic cancer or endocrine pancreatic cancer, now the researchers have shown, particularly Dr. Bailey, Dr. Collison, and Dr. Moffitt, is able to define pancreatic cancer into subtypes, like a basal-like pancreatic cancer, classical pancreatic cancer, or immunogenic or mesenchymal pancreatic cancer. And what they found that the basal-like pancreatic cancer are the one which are low in GATA6, which is a transcription factor. And they found that this is a predictive marker, not only in terms of knowing that these tumors will not respond to FOLFIRINOX, but also is a poor survival marker. And most interestingly, we also learned that these patients seem to have more of a PD-L1-like expression that also allow that these patients may benefit from immunotherapy. On the other hand, the classical or immunogenic types are the tumor types which are high in GATA6. And GATA6 is something that people who are hematologists are used to test it anyhow, and that is a predictive marker to response to fall-free knocks. So I think we are going in that direction slowly and steadily. I think that's becoming more exciting that now we can subclassify the patient's phenotype and decide the right therapy from the patient instead of giving him the therapy which will not only provide any benefit but also will cause toxicity. So moving on, why it is so difficult to treat pancreatic cancer? I think partly it is the complexity and the redundancy of the signaling pathway. We all learned that a single targeted agent probably less likely to be effective. So that's important. Heterogeneity in pancreatic cancer cell is well known. We also know there is a surrounding desmoplastia or desmoplastic syndrome, which is basically a halo of scar tissue around the pancreatic cancer core of the tumor that may inhibit or prevent the delivery of chemotherapy. And last but not the least, we also learned that the pancreatic cancer stem cells, such as CD44, CD24, they're really highly tumorigenic and they can generate phenotype diversity within the tumor, and they may also make the tumor resistant to standard chemotherapy. So definitely it really put us into that thing. And the way I started my journey from NCI, that start thinking of pancreatic cancer as a black box and try to really, learn from this black box, but also try to break this box and think outside the box. So I think that really kind of led us. So what we really realized that, we need to attack pancreatic cancer from different perspectives. And again, going back to the basic principle I told earlier, that think about the cancer, think about the patient, and think about the drug. So one of the important paradigms that we worked very earlier in our career was really trying to apply the pharmacogenomics principle to improve the outcome in pancreatic cancer. So the first thing is that we know that capecitabine, which I mentioned earlier, or Xeloda, is an oral 5-FU chemotherapy. And the last, step of the conversion of Xeloda into 5-FU is really, catalyzed by thymidine phosphorylase enzyme, which is shown over here. At the same time, we learned from the NCI cell lines that the cancer tumors has more thymidine phosphorylase than the normal cells. That could be the reason that we have tumor localization of the delivery of high doses of chemotherapy, sparing the rest of the body, preventing any side effects from the chemotherapy. Thirdly, we also learned in 1994 from a study done by Dr. Swada in the memory breast tumor cells, where he found that a single dose of radiation therapy can upregulate thymidine phosphorylase always to 20 times if given around day 13 or 14. And last but not least, when we were talking about Gemzar, capecitabine was an attractive drug, oral drug at that time, and that can really allow us to have a convenience of delivery to the patients. So based on this thing, we did an experiment, a preclinical experiment, where we took, the BX PC3 pancreatic, cell lines and xenograft into the mouse model. And what we did, basically, we transplant the tumor into the left thigh and the right thigh. And then what we did, we basically put a sheet on one thigh and we radiate the tumor, and we radiate the tumor alone with radiation therapy. We radiate it with radiation plus capecitabine, and we also radiate with capecitabine plus Celexa or Celebrax, which is one of the COX-2 inhibitors. And after 28 days, we sacrificed the animal and looked at the response of the tumor to different combinations and single therapies. What we found, as you can see in the cartoon that says in the graphs of irradiated tumors, in this thing, we found that the best response was really when we give combination of capecitabine with radiation therapy regularly. We also found that, capecitabine has an impact alone. We realized too, we also found that high dose of radiation therapy, which we found previously in the GIRSTIC trial, has an impact on pancreatic cancer. But the most surprising and shocking and interesting, we found that in the shielded tumor, even the tumor was shielded and couldn't get the direct radiation therapy, the best benefit was again found in the animals when they were given capecitabine plus radiation therapy together. And I think that was an important thing because that led to understand what we call about abscopal effect. Abscopal effect is really defined as the impact of or effect of radiation therapy in the area which is not radiated. This is the effect which was first defined by Dr. Moll in 1953. At that time, he defined this is the effect of radiation to the area not radiated. He also put it there that this is not a bystander effect or like a junction to junction thing. And he really at that time postulated that probably there are some chemokines or chemicals produced by the tumor which may travel through and cause the impact of radiation therapy to the distant area. This is somewhat another thing that what we call radiation recall phenomena, that certain chemotherapies bring back the side effects of radiation therapy. So based on this experiment, we led to perform a phase 1 and a phase 2 study in pancreatic cancer with the locally advanced pancreatic cancer, where the patient will undergo an endoscopic ultrasound biopsy before receiving the radiation therapy, and will measure the thymidine phosphorylase enzyme, particularly also some other markers like TNF alpha, because the studies have shown that TNF alpha could be one of the reasons of chemokine that can lead to escalation of the thymidine phosphorylase. And the second biopsy was performed during week 2. What we found in this study, that this is the first human study by textbook that really showed upregulation of thymidine phosphorylase by giving dose of radiation therapy and really lead to a better outcome because there was 25% response rate. In addition to that one, this is the first human study that laid down the foundation for the dose of capecitabine to be combined with radiation therapy given at the dose of 800 milligram per meter square Monday through Friday during the dose of radiation therapy, and become a standard of therapy for patients with pancreatic cancer. Moving on, again, we all know that in medicine, not everything is that science. A lot of times we go from the back door. Similarly, when a regimen is used in the metastatic setting, then we move to the—
Professor Saif, we have only 2 minutes left.
Okay, so I think I will go to— So I think the key element to understand that pancreatic cancer is a disease which really takes a whole village to take care of it. I think I wanted to just say one thing, that we are now working on the organoid. And organoid is basically creating a miniature of the pancreatic cancer that really allows us to understand, the sensitivity and the resistance of chemotherapy. So this is an important study that we're doing in collaboration with Cold Spring Harbor Laboratories. So I think the bottom line is that if you ask what we need to do to improve our outcome in pancreatic cancer, I think we need to design our clinical trials in a potential new manner. It is very important to identify the biomarkers. We also need to look for alternate strategies of therapeutic targets. We need a better way of selecting the patient. We also need to make sure the patients go to high volume centers, particularly for the surgery. A multidisciplinary approach is crucial to treat pancreatic cancer. We definitely are building tools for high-risk patients to be looked for pancreatic cancer. And last but not the least, the personalized medicine needs to enter pancreatic cancer, such as the example of BRCA2, where these patients can benefit from PARP inhibitors. Last but not the least, the roadmap for the future is very complex, but instead of getting scared of this one, I think all we need to put our hands together and work together, and hopefully one day will come when we will see on the New York Times that there's a cure for pancreatic cancer. Thank you very much.
Thank you, Professor Saif. That was a real tour de force of everything about pancreatic cancer. And I really admire you, and you inspire me when you become so involved with the disease that really is begging and pleading for treatment. So thank you very much. There'll be some questions perhaps in the chat, but we do need to move on to our next speaker, and I'm going to ask Dr. Ocampo to introduce him.
Good afternoon, everyone. It is my pleasure to introduce our very own Dr. Jeffrey Goldberger, Chief of the Cardiovascular Division at the University of Miami Miller School of Medicine. Dr. Goldberger completed his internal medicine residency in the Bronx Municipal Hospital Center in New York. He then pursued his cardiology fellowship in the University of California in San Francisco, followed by a fellowship in electrophysiology in the same institution. He has held multiple important leadership positions in Northwestern University and joined us in UM in 2015 as a professor of medicine and chief of the cardiology division. His research in electrophysiology has resulted in multiple publications in high-impact journals, and he was also recently awarded with the Robert J. Meyerberg Outstanding Academic Cardiology Faculty Award this year. Dr. Goldberger's presentation today will be about updates in cardiovascular disease. Please join me in welcoming Dr. Goldberger.
Okay, thank you so much for that introduction. Is the screen sharing correct? Have it on the right mode?
Yes.
Yes.
Wonderful. All right, so thank you for this opportunity. I really appreciate it, and thank you for that great introduction. I've prepared for you this afternoon a smorgasbord of cardiovascular updates. You can see that there are a couple here that are going to be a little reboots of some common medications that we use in the cardiovascular space. Talk about some new medications that are emerging in the cardiovascular space. A little bit about COVID-19, and then finally about cardiac arrest. So this will be a little bit rapid fire, and we'll try to get done with this before Dr. Weiss uses the hook to pull me off stage here. So very briefly about aspirin. So I think people may have heard the U.S. Preventive Services Task Force came out with this draft recommendation back in October. The public comment period just ended, but essentially they're considering recommending that people ages 40 to 59 should discuss with their clinician whether to start taking aspirin if they are at risk for cardiovascular disease. But people over 60 should not do this. I really just want to point out to everyone that this is very similar to already the existing ACC-AHA guidelines on primary prevention of cardiovascular disease that were published in late 2019. You can see here, low-dose aspirin might be considered for primary prevention of atherosclerotic cardiovascular disease among select adults age 40 to 70 who are at high risk but not at increased risk of bleeding. So their age cutoff here is 70 rather than 60. Low-dose aspirin should not be administered on a routine basis for primary prevention among adults greater than 70. So again, here it's just a risk-benefit question about the potential benefits of aspirin for prevention of atherosclerotic cardiovascular disease in contradistinction to the risks associated with bleeding complications. So we'll await for the final recommendations from the Preventive Services Task Force. So beta blockers post-MI are a very interesting topic. I think anybody who's trained in the last 40 years has grown up with the knowledge that there are randomized clinical trials, multiple randomized clinical trials that have demonstrated that beta blocker therapy after myocardial infarction improves survival. The important thing to realize here is that the vast majority of the randomized clinical trials were done in the 1970s and 1980s. So these data are extremely old. The therapeutic approaches to myocardial infarction in 2021 is vastly different than it was back then. There was no revascularization, no statin therapy, a lot of other things that were not available back then. So there's always a lot of question about whether we still need to be using beta blockers, which patients should be getting them, how much beta blockers we should be using, and how long patients should be getting treated. So this was a topic that was of particular interest to me, and this is from a publication in JACC in 2015. This is a registry of 6,600 patients. And what we were concerned about is, at the time, although the problem of underuse of beta blockers had essentially been resolved by quality initiatives by the hospital associations, the American Heart Association, by mandating as a quality initiative beta blocker use after MI, they've essentially got over 90% of patients to be treated with beta blockers. But what we noticed was that even though patients were being treated with beta blockers, they were often being treated with very low doses of beta blockers. And if you go back to the randomized clinical trials that were done in the 70s and 80s, they actually used target doses that were fairly high. So metoprolol turns out to be the most common beta blocker used after MI. So I'm just going to use that as a paradigm for the next couple slides, but this applies to any beta blocker that's been studied, and we can always calculate a target dose. So for metoprolol, the target doses that were typically used were 200 milligrams per day. And then we can calculate based on what patients are actually taking, what percent of the target dose they're taking. So if they're taking 100 milligrams, they're taking 50% of the target dose. 50 milligrams per day is 25% of the target dose. And what you see here is a plot of survival after myocardial infarction based on the percent target dose that the patients were taking at discharge. And you can see here, this is the survivor curve for patients not taking beta blockers. If you take any beta blocker, you do much better. But if you look at this curve here, the top curve, the patients that do the best are taking about 25% of the target dose. So metoprolol, that would be 50 milligrams per day. So what we wanted to know was, well, what happens after a year? What happens if we take a look at a year and see what the effects of beta blockers are beyond a year after survival with a myocardial infarction? So the first thing we had to do is to figure out, well, what dose of beta blockers are patients taking a year later? So what you see plotted here is the beta blocker dose at discharge and then the distribution for the doses at 1 year. And you can see pretty much no matter what dose you were at discharge, about 60% of patients remain on the same dose at 1 year. And then there's a distribution. Some of them change. If you're not on beta blockers, you can see how many were on beta blockers at a year, and every dose has its own distribution. So when we looked at the, this was published this year in the Journal of American Heart Association, and this is the survival curves. You can see that they're fairly overlapping. So it starts here at 1 year after myocardial infarction, and this is the survival probability. But this curve up here with the 25% dose does tend to stick out a little bit, and this was statistically significant. The other doses were not different from patients not taking any beta blockers. So what I have for you now also is a little bit of an update in 2022, because this is yet unpublished data. This is now data from the Danish National Registry, where they record all their patients who have myocardial infarction. And the study size here is about 10 times of what we had in the Obtain study, so 65,000 patients. And the other thing that they're able to do in this study is they have a pharmacy database, so they can actually assess not only prescription dose beta blockers, but actual use, because they know when the patients go and fill their pills. And presumably if they're filling their prescriptions, they are consuming them. So what we plot here is, again, this is now the adjusted mortality. So this is compared to no beta blockers. And this is 12.5%, 25%, 50%, and 100% of the target doses. So you can see, again, here you see some graded reduction in mortality based on dose. So the very low dose gets you very little reduction. 25% gets you most of the reduction, and then maybe a little bit more at 50% of the target dose. You don't get much more mortality reduction when you go beyond 50% of the target dose. And then when you look at years 1 through 10, so you recalibrate it 1 year, you can still see the same pattern where you have persistent effect of beta blockers after myocardial infarction. So I think the registry data strongly support continued use for beta blockers. It seems to still provide some important benefit. But the good news is one does not need to target the same doses that were used in the randomized clinical trials. Again, this is registry data. It's not randomized clinical trial data, but the data are fairly consistent across many different paradigms. So with that, let's move on to talk about SGLT2 inhibitors in heart failure. This is a data from the Emperor Preserve trial that was recently published in the New England Journal of Medicine. So this is a study of 6,000 patients with class 2 to 4 heart failure who have preserved ejection fractions above 40%, and they are randomized to EMPA or placebo. Primary outcome was a composite of cardiovascular death or hospitalization for heart failure, and median follow-up was a little over 2 years. I'm not going to go through the patient characteristics, except to note that only about 50% of the patients were diabetics. So about half of the patients were non-diabetics in the study. And it turns out that diabetes did not influence the outcome. And here you could see the primary outcome for the composite of cardiovascular death or hospitalization for heart failure. And you can see EMPA is associated with a reduction in the primary endpoint. Hazard ratio is 0.79. So you're talking about a 21% reduction related to EMPA use. This year, we also had published a meta-analysis of SGLT2 inhibitors in heart failure. This is the data looking at mortality. So this does not yet include the EMPA preserved data. And you can see here that the point estimate for the hazard ratio in this meta-analysis is 0.83. So you're talking again about a 17% reduction in mortality. There are about 13,000 patients in this analysis. And again, about a third of the patients in this analysis were not diabetic. So this seems to be an effect that we see both in diabetes and non-diabetics with heart failure. So it always intrigued me, what are the potential mechanisms underlying the effects here associated with cardiovascular benefits? And there are many reported potential effects here. Could be related to preload and afterload effects, cardiac metabolism, bioenergetics, sodium-potassium exchange inhibition, effects on cardiac fibrosis, and effects on adipose cytokines and epicardial adipose tissue mass. Generally, when there's a list that's this diverse in terms of potential mechanisms, it means that we really don't know. But I think this is going to be a fertile area for further research. One of the interesting areas that was looked into and also published this year, this is work from one of our former residents and fellows, Gilson Fernandez, who did a meta-analysis of the SGLT2 trials, looking at the effect on arrhythmias and sudden cardiac death. And this is included over 34 randomized clinical trials. This is a very challenging analysis to perform because most of the studies do not report on this. You have to actually go back and look at the adverse event reporting. And there are three different classifications here that they look at. They look at sudden cardiac death, which is what's plotted up here. They look at something called sudden death, and they look at cardiac arrest. And you can see for the cardiac arrest and for the sudden death endpoints, there's really no effect, but there was a little bit of an effect that was observed here in reduction of sudden cardiac death. So there may be an arrhythmic effect as well with SGLT2 inhibitors. All right, so move on to the next medication, novel medication here in terms of the GLP-1 agonist. This is another publication this year in New England Journal of Medicine, looking at the effect of semaglutide in patients with overweight or obesity. These are non-diabetic patients. This was the step 1 study. And what they're plotted here is the body weight change from baseline by week. And this is the observed in-trial data. You can see in placebo, you get about a 2% reduction in weight from baseline. Whereas with semaglutide by a year, you get about a 16% reduction in body weight. So obviously, there's a lot of cardiometabolic changes that go along with weight loss. There have been prior studies that have looked at cardiovascular effects of the GLP-1 agonists. The leader study showed some beneficial effects in terms of cardiovascular endpoints. But what I'd like to do is just focus on an area that we're looking into, which is atrial fibrillation. This is a study that comes from Australia, where they are very focused on risk factor modification for treatment of patients with atrial fibrillation. And this is an observational study looking at about 300 patients in whom they worked on this risk factor modification. Weight loss is an important component of that. So in this group, they had less than 3% weight loss. In this group, they had 3 to 9% weight loss. And in this group, they had 10%, over 10% weight loss. Now, we're going to look at what happens to the patients in follow-up. Now, treatment was not only weight loss, they could have been treated with other medications or catheter ablation, but we'll look at what happens to atrial fibrillation over time. So in the purple is the patients who progress from paroxysmal to persistent atrial fibrillation. If you don't have any significant weight loss, about half of them progress. If you have moderate weight loss, about a third of them progress. And if you have significant weight loss, only 3% progress. So these are people in yellow now who have sort of reversal, go from persistent to paroxysmal. If you have no weight loss, virtually nobody has reversal. About 17% have reversal if you have moderate weight loss, and then twice as many, 36%, have reversal if they have significant weight loss. And then perhaps the most impressive group here is in the gray. Those have freedom from atrial fibrillation, so no further atrial fibrillation. In the patients with no weight loss, 25%. In the patients with moderate weight loss, about a third. And then in patients with significant weight loss, it's about a half. So you can see that, that there's a strong dose response here in terms of the effects of weight loss on atrial fibrillation. So that brings us to the study that we're performing here at This was developed in conjunction with Gianluca Iacobellis and the rest of my colleagues here in electrophysiology. It's called the LEAF study, where we're looking at the effects of liraglutide, another GLP-1 agonist, effects on atrial fibrillation. I'm not going to go into this in detail, but it's a randomized clinical trial in patients who are having catheter ablation for treatment of their atrial fibrillation. So at enrollment, they get randomized to either risk factor modification or risk factor modification plus liraglutide. And what we've done in this trial is we've initiated a 3-month treatment prior to ablation. So this is to allow either, you could call it medical stabilization or substrate stabilization or optimization, trying to get the patients to have significant weight loss and also perhaps reduction in epicardial fat prior to their catheter ablation procedure. We've enrolled over 40 patients so far in this trial. Just want to share with you what we're seeing so far in terms of the weight loss. So again, we have enrollment and we're looking now at just the change in weight from enrollment. In patients who get risk factor modification only over the first 3 months, they tend to lose only about 3 pounds, whereas they lose almost about 12 pounds if they get randomized to liraglutide. Preliminarily, we're seeing very, very good outcomes with catheter ablation in these patients. So hopefully we'll be able to finish this trial in the coming year. So moving on to COVID, one of the important questions that came up at the beginning of the pandemic is what to do with patients who were taking ACE inhibitors or angiotensin receptor blockers. There's a lot of concern that these medications could lead to upregulation of the ACE2 receptor, which is the binding receptor for the COVID virus. And there were a lot of arguments back and forth whether these should or shouldn't be stopped. This was a randomized clinical trial that evaluated whether to do this. And again, just wanted to give a shout out to Carlos Alfonso, who was our PI here at for this randomized clinical trial. They looked at a variety of different endpoints, all-cause death or ICU admission or invasive mechanical ventilation. It's a fairly small trial, only about 150 patients were actually randomized, but you could see in both of these endpoints, there was really no difference. So the recommendation was that you do not need to discontinue these medications. Last year, Dr. Mitrani presented in this forum, in the spot, our data and information about screening the athletes for myocardial involvement from COVID. There have been, in the summer of 2020, there was some concern based on some MRI studies from Europe that there could be a fairly high rate of myocardial involvement, even in asymptomatic or minimally symptomatic patients with COVID. What you see here is an MRI, and you can see this ring of hyperenhancement in the epicardium of one of our athletes, indicating some fibrosis and scarring. So this is evidence of some myocardial injury from COVID. Over the year, there's been a lot of information that's come out, mostly some large-scale studies. See here our data from the Miami protocol. Again, involved a lot of people in this institution. Dr. Meyerberg, Dr. Hare, Dr. Lowry, Dr. Best, Dr. Matrani, and several of our fellows. And you can see that in the early reports, there was a fairly high reported rate of cardiac injury, but you can see in the larger reports and our reports, generally the numbers are pretty small in the 1% to 5% range. So it's very uncommon, but nevertheless it does occur, and there still needs to be some sort of screening for it. We do also have some follow-up information because we had 5 athletes who had presumed myocarditis, and now we have more than 6 months follow-up. 2 have resolved and have been cleared to return to their sport, but 3 are still undergoing follow-up for persistent issues and problems. So this is something, again, very, very uncommon, but it does occur, and it is something that, that we need to pay attention to. All right, so the final topic that I want to raise for your consideration today in our smorgasbord of cardiovascular updates is what's going on with cardiac arrest, and are we making any significant progress? So cardiac arrest is something that's reported to occur out of hospital cardiac arrest in about 350,000 Americans per year. That number has really not changed all that much. You know, there's a lot of active interest from a lot of different groups on how we can impact that, and we'll talk about that in a few slides. But what I'd like to present to you is a couple of studies that were also published this year, looking at some of our approaches to management of patients with cardiac arrest. So the first one, also published in this year in New England Journal of Medicine, is the Ttm Ii Trial. This is looking at targeted temperature management. The 2 groups were normothermia and hypothermia. So traditionally, in the last decade or so, we've gone to treating patients with hypothermia, the target temperature of about 33. So that was one group, but was never clear whether hypothermia is better than normothermia. So again, this is targeted temperature management to prevent the temperature from getting above 37. And you can see here that they've targeted 37 degrees and they've pretty much maintained it. You can see that there's a lot of variability in temperatures in both groups. So here you look, we have the survival. This is now out to 160 days. And you can see that there is absolutely no difference in survival between the normothermia and the hypothermia group. I'll also point out that the survival is about 50%. So once again, these are patients that have now survived an out-of-hospital cardiac arrest and survived enough to be able to be entered into a clinical trial and to be treated with one of these targeted temperature management programs. And nevertheless, the survival is only about 50%. Another major question that comes up in the management of patients with out-of-hospital cardiac arrest is whether to perform immediate angiography or to delay or perform selective angiography. Obviously, patients who come in with ST segment elevation MI, everybody agrees those patients should go to the cath lab and should be revascularized. In this study, they did a randomized study in about 500 patients, looking at immediate angiography versus delayed or selective angiography. And once again, there was no statistically significant difference in the outcomes of these 2 groups in terms of survival at 30 days. Again, you'll notice that survival is only about 50%. So this is a very, very high-risk population. So what can we do to really improve our performance in patients with cardiac arrest? So we're working with the EMS groups in Florida to try to develop a statewide initiative to develop primary resuscitation centers and comprehensive resuscitation centers. So this is sort of mimics the intervention centers for stroke. So this is something that will hopefully be able to initiate standardized bundles of care that can improve survival. And then the other concept that I'd like to raise is to expand the chain of survival. So the American Heart Association has put together this chain of survival, which includes notification, CPR, early.
However, they never drew either the CBC or the BMP that Dr. Galante ordered.
Okay. Early defibrillation, advanced cardiac life support, and then post-arrest care. And this is obviously very, very important. But I think we need to go beyond that and expand the chain of survival and start to think about what we can do before the cardiac arrest. So here we have the thinker. We have to try to think about ways we can prevent people from having cardiac arrest. Because once they have cardiac arrest, they first have to be resuscitated. And then even if they're resuscitated, they have only a 50% chance of survival. So we want to try to capture these people before they have their cardiac arrest and try to initiate appropriate treatments up here where we could have a greater impact than if we wait for them to have a cardiac arrest. So there's my cardiovascular update for 2021. Happy to take any questions.
Yeah, thanks. That was really a smorgasbord, and the most delectable dishes were served. And anybody who's interested in having more, obviously can go back to those very current and relevant papers. We have just a quick few minutes for some questions. I'll ask one, what do you think is the physiology behind the lower dose of beta blockers being more effective in terms of survival than the higher dose?
Yeah, so that's an excellent question, of course. So I think it's the same thing with the aspirin issue. I think it's a risk-benefit issue. So I think higher doses of beta blockers, patients are more susceptible to bradyarrhythmias. There have been some monitoring studies in patients post-MI that have demonstrated a remarkably high rate of bradyarrhythmias in these patients. So I think that makes them more susceptible. Another potential mechanism, we know the benefits of exercise and cardiac rehab after a myocardial infarction are really, really important. Higher doses of beta blockers may actually inhibit that. So there are a number of different potential mechanisms that can do that.
So we're at the top of the hour. I want to thank both our speakers for excellent presentations today. Remind everyone to claim their CME and MOC credits on the link that's in the chat. And please stay safe, be well, and we'll look forward to seeing you next week. Thank you. Have a nice day.